Hello and welcome, everyone. Thank you for joining and listening to this recorded webinar. My name is Meg Beyer, and I work for the McSilver Institute, and I'm part of the Managed Care Technical Assistance team. I'm excited to join you today and to introduce two of our state partners who are going to walk us through some of the material and content around adult behavioral health, home and community-based services, infrastructure funds. So with that, I'd like to pass this along to my colleagues from OMH, Doug and Emily, who will take us through some of the content. I'll be back towards the end with my colleague, Dr. Andrew Kleek, to talk about sustainability and some resources at the end of the presentation. So Doug and Emily, take it away.
Thank you very much, Meg. This is Doug Ruderman
and Emily Hetzel.
And we're with the Division of Managed Care here at the Office of Mental Health. And the reason why we wanted to record this brief webinar is to try to clarify some questions that we've heard from the field regarding these funds and how to access them and what is it exactly that we're looking for and seeking with the use of these funds. So we usually start with some data, and that's what we have here, this inverted pyramid. If you look at the purple line, which says HCBS assessed, and that has the number 19,465, and you go down to the point at the bottom, HCBS claimed, you see 2,458. And that is what these funds are primarily geared for, is to increase the number of people claimed to try to get it as close to the number of people assessed and found eligible as possible. So we're really talking about that workflow. Certainly, there's a lot of people that are enrolled in HARP that haven't been assessed, and we'll talk a little bit about that as we go through the webinar. A little bit more data, and what this shows you is the comparison of previous month report, and this is 723 data. So on 723, you can see for the top column, HARP enrolled, HARP health home enrolled, and so on. Those were our numbers as of July 23rd of 2018. The second row, compared with the previous month, is the increase that had occurred since the prior report, which was in June of 2018. And then there's shows what the percentage change is. What's very interesting to note here is that there are many more people that were assessed in the month, so we have a lot of catch-up to go to get to that 110,771 people, because everybody enrolled in a HARP must be assessed on an annual basis, and we're only at somewhere below 20% of that currently, but we did increase by 900 people in the month that we're showing here. Another interesting fact on this slide is that the HCBS eligible 540 increase, and the level of service determination, that's what LOSD means, increased by 370. That's a 68% of those people that were found eligible, there was a level of service determination, whereas prior to that we were at 44%. So that shows that in that month that trended up also. So we're moving in a good direction, and we're hoping that these funds will even push us further along. This slide here is just for you to link to different resources that we have available either on the MCTAC website. The first two are what we euphemistically called Roadshow 1 and 2. And then the third one was how to complete the infrastructure proposal application. And then below that, you'll see that there's the guidance regarding infrastructure funding that's available on the OMH website. So we're going to go through a little overview or refresher regarding these funds. And so we start with that what we've been saying is that these funds are targeted to increase the capacity and provision of behavioral health HCBS services for adults in New York State. Individually by MCO, what we're asking the managed care organizations to do is to create integrated and comprehensive strategies for their heart members that are going to increase the utilization of behavioral health HCBS for their members. The MCOs can do this either by soliciting proposals from providers, or the providers themselves might generate proposals on their own and present them to the different plans. These individual proposals can be very broad and can be entirely an integrated and comprehensive strategy, or it could be just one little piece of what the MCO's integrated and comprehensive strategy is. And all of this, and we talk about this in every webinar, no matter what we do, it's really going to take a partnership amongst those providers, the health home care managers, the recovery coordinators, and the plans to make this work. We also want you to recognize that this gives an opportunity for there to be creative solutions in different catchment areas, because not every area of the state will present with the same need or the same perhaps obstacles to moving people forward into HCBS. And so that's where that conversation with the plans may differ. You might be having, if you're in Western New York, be having a conversation with the plan, and they need something to occur there to get this moving. And it might be a completely different conversation that the plan is having with somebody in Long Island, if they cover both of those regions. So the plans don't have to be the same, but wherever the plans are, they need to be comprehensive. The whole idea is to build a sustainable infrastructure so that as we increase the use of behavioral health at HCBS, we have the capacity to continue to provide that service as we move forward. And we'll talk a bit more about sustainability later on, because that was one of the areas where we heard some questions from the community. And these funds can also support the Recovery Coordination Agency implementation, and we provided a link there to the guidance regarding that. And what that is, for those of you who may not know, is that it is the state designated entity that will allow access for people to the eligibility assessment and plan of care for HCBS services if the person chooses not to be a member of a health home. If they are in a health home or would like the services of a health home, then we would go through the route of having the health home care management agencies do the assessment and the plan of care. So these are the different types of agencies that are eligible to receive, or entities that are eligible to receive these dollars. It's self-explanatory. The actual HCBS providers, the recovery coordination agencies that we just spoke about, health home care management agencies. We're also, for behavioral health IPAs, for those providers out there that are a member of an IPA, we're allowing the IPA to submit an application or proposal for these funds, and they'll figure out how to distribute it amongst their members, and then also training entities, so that these different entities that we just mentioned could be trained and they understand what these services are and how to provide them. The allocation itself, so the program is funded to $50 million, and the funds are targeted, as I said earlier, for the HCBS workflow, getting heart members from assessment through the HCBS service provision, and that's it. We're not looking to get anything else done with these funds other than moving people through the workflow, get them assessed, get them to a service if that's what they want and they need. Each managed care organization will receive a funding allocation commensurate with its statewide HARP membership. We can't lock that down to a number because that number moves all the time as people join HARPs or leave HARPs for whatever reason. But there's funding to each one of the HARP products that are out there and companies that have a HARP product. And these funds are not allocated by region or county. So the managed care organization can target funding where they think it is most needed in the areas where they have members. Doesn't have to get spread like peanut butter. Okay. Funding details. Okay, so the proposals must be under contract by March 31st, 2019. Anything that's not under contract by that date is going to be returned to the state. Okay, so in order to do that, we have some urgency here, and proposals are starting to trickle in as we talk to the managed care organizations, but they really need your proposal submissions by mid-September. Some might be able to have a little bit of flexibility, but really we are strongly advising you to get in touch with the MCOs, to get your proposals in by mid-September, because there's going to be some back and forth negotiation on the proposals. Then you have to start to go into contract with the plans and get these funds contracted. And for some plans, that could take 90 days, sometimes more, sometimes less. But when you start to back up from March 31st, we're really getting close to the drop-dead date for submitting of proposals and getting them all funded. We have another link there to the MCTAC plan matrix, which for those of you that have not gone to the MCTAC website or perhaps not gone to see the matrix, gives you information about each plan and different contacts for different things that the plan has experts in, and one of the ones that they have expert staff that they have a point of contact for is for the infrastructure funds. And we have a slide later on where we pulled out each plan's contact person and contact information, and we'll show you that slide later on. The other thing is that the funds must be expended by March 31st, 2020, with unspent funds returned to the state. Now, I want to clarify what that means. Okay, we're going out there, and the other reason why we're really talking about urgency is the quicker you go into contract and start receiving these funds, the longer period of time you'll have to spend the funds. Okay, because March 31st, 2020 comes, and any funds that are not spent by that point are going to come back to the state. The funds flow, okay, so the providers and the MCOs need to work together to develop milestone metrics and outcomes that demonstrate an increase in behavioral health HCBS. Okay, so what we're saying here is basically, and this is important for you to understand the fund flow. You're going to, in your proposal, and as you negotiate with the MCO, you're going to determine what it is that the MCO is buying from you and what milestones you have to achieve to get continued payments from the plan. So the payments will be prescribed in the contract. You'll likely get an initial allocation of money, which will get you started on your plan, on your proposal. And then, as you go forward, as you achieve metrics, then you'll get paid more money per your contract. So we're not going out there and taking money back if you don't achieve a metric. What's going to happen is you're not going to get more money. Okay, so once you get the money from the plans, unless if you're committing some kind of fraud, you're going to get to keep that money. okay? So we're not looking to go out there and to take money back once it's been distributed. And it's going to be between the awardee and the managed care organization to determine if and when metrics are met. There are two kinds of ways to spend this money. Some of it is one-time expense, and we gave just a couple of very simple examples here. Consultants to assist in the proposal implementation, because a consultant isn't an ongoing expense. It won't be an employee. It'll be somebody you pay to do something for a specific time period, and then they're done. Training, and if you remember, we talked about training entities. Well, training doesn't necessarily need to have to be ongoing throughout the course of the whole proposal. You might have to do some training right up front, and then that expense won't continue beyond the lifetime of these funds. And then equipment. There might be a need for you to have certain equipment in order to more efficiently provide HCBS services. Most of the funds we expect, though, are going to go to sustaining infrastructure. And this is where we're clarifying what we mean by sustaining infrastructure, and where Dr. Kleek will talk a little bit later in a little greater detail about how you might calculate that. But what we're saying here is that we're defining it for you now as the estimated number of HARP enrollees you will need to serve and or assess per calendar year in order to sustain your ability to provide New York State eligibility assessments and or behavioral health HCBS beyond the infrastructure funding period. So we're not saying, this is another way to define something by not defining or defining it more clearly. We're not saying that whatever it is that you're doing with these funds right now, you have to commit to continue doing it forever, because you may not get the volume that you're proposing. For whatever reason, things might happen that you can't continue to sustain at the same level that you expected to or were able to do during the funding period. But what we do expect is that you're going to build an infrastructure so that you can provide some level of assessments and or HCBS services on an ongoing basis. We don't want these funds to go out there for this period of time until 2020, and then all of a sudden our capacity to provide these services disappear. And we've updated the infrastructure proposal application and instructions to include this definition. Excuse me. And now we hand it over to back to McTack.
All right. Thanks so much, Doug. So this is Andy Kleek, and I'm the director of McTack, and I am going to just talk for a couple minutes about sustainability and best practices. So, I think Doug did a really nice job of walking us through exactly kind of the rules of the road associated with this. And so I just want to talk, and I'll use a couple of examples in the middle of it, just to kind of talk through some of the things you're going to want to consider as you build infrastructure and use these funds, and with an eye towards sustainability. And I'm going to break it into two broad categories. And one is staffing, and one is the purchase of an ongoing maintenance of technology, or I might even refer to it as stuff. So I'm going to start with the purchase of technology and address that first, because I think it's really important. So one of the big things associated with these funds that we can do is that you can buy technology, and that could be in the form of electronic health record. It could be in the form of data analytics technology and dashboards and those kinds of things. And I think what you want to be really mindful of is that these funds are an excellent use. An excellent use of these funds is purchasing that technology up front. But as you purchase that technology, you need to keep a real eye on the ongoing maintenance costs for that technology. So if the software program you're going to buy costs $100,000 a year, I'm making the numbers up, and it costs $10,000 to sustain it every year for maintenance, then you need to make sure that you build into your sustainability budget that you're going to have enough volume to adequately meet that $10,000 a year cost, or it's really not worth buying the thing to begin with. The other piece of this, and I think this is critically important, especially when it comes to things like electronic health records on the IT side, but also even evaluation tools and technology associated with evaluation, is there's also person costs associated with that, right? So if you buy some data warehouse to do ongoing evaluation, you also need not only IT professionals to continue to update that software, but you need folks who can actually do the evaluation, who understand the evaluation. And so really there's two costs associated with these technology purchases. One is the ongoing maintenance costs, which you have to think about the volume. And then also, in addition to that, is the kind of ancillary staff costs that come along with it on a year-over-year basis. So as you're thinking about what technology purchases and what infrastructure purchases you want to make, you want to be really mindful of both the staff and the ongoing staffing costs associated with those purchases, as well as the ongoing maintenance costs on the technology side associated with these purchases. The other piece of this to be really thoughtful about is also staffing. So, for example, you may decide to invest some of these funds in staffing who might or might not be providing direct services, with the idea that you will eventually build those staff up to a certain level of productivity. But you need to be thoughtful as you do that about what's the actual level of productivity each of those staff is going to have to be sustainable without these additional infrastructure funds going forward. So the idea is that before you engage in this process, before you hire staff, before you think through exactly what your program is going to look like long term, you're going to want to do some really careful business planning around assumptions. And as Doug said, assumptions change based on a lot of things. But some assumptions about what are the actual unit costs, so how much does it cost to deliver a unit of services, and how many services are you going to need in order to sustain a particular staff member or a particular model or volume of care. And not only is it the staff cost, but as we mentioned earlier, it's also the space cost and those kinds of things. Another thing to just be mindful of is since these services are supposed to be delivered primarily in the community, one area that you don't need to necessarily invest a lot of funding in is kind of those space costs. The other thing you'll want to think about, first of all, there's the technology piece in those buckets. Second of all is the number of clients you're really going to need to have in order to sustain a certain level of volume amongst and staffing. And then finally, the other thing I just want to really highlight is in addition to those issues, I think the other piece of this is really how you're going to staff those positions. And this will vary tremendously across providers, across populations, and also geographically. And so whether you want to hire full-time staff, so staff that are, full-time employees of the agency, either full-time working directly in HCBS or full-time split across HCBS and perhaps a PROS program or perhaps some other kind of program, or to what extent you want to hire per diem staff. And there's advantages and disadvantages to both. And but I wanted to highlight that if you have a very high volume program and you anticipate that you're going to have a tremendous amount of HCBS volume around a particular service, then you may have enough volume to support a full-time peer support specialist, right? But if you're in a particular part of the state that you don't think, if you're in a rural county or a part of the state or part of a city where you don't think you're going to have enough volume to support a full-time person, then you may want to think about hiring per diem staff. There may be somebody in the community, there may be a number of people in the community who are looking for a little extra work, or particularly in the interest of peers, to somebody who's not necessarily interested in working full-time but wants to work part-time, who would be an excellent fit to provide those services, but wouldn't necessarily be a full-time staff. And I think just to think through both of those issues as you go forward, to really figure out exactly what the best model is going to be for your particular HCBS array of services. It's going to be different. If there's 150 service organizations around the state, there'll be 150 versions of this. And you want to just be really thoughtful as you think those through. So I think with that, I'm going to pass it back. I think I'm passing it back to Meg at this point to kind of wrap us up.
Yep, that's right. Thanks, Dr. Kleek. So I'm going to jump to the next slide, which is just a review of the specific managed care organization infrastructure contacts. So Doug had mentioned earlier in the presentation that, you know, part of the importance of this work is partnering with the MCOs to make sure that what you're working on for this infrastructure work fits. And so these are the specific contacts at each of the managed care organizations for infrastructure. So we've listed them here on the slide so that as you're viewing this webinar and as you review this information on the MCTAC website, you have all of the information for the MCOs right here in front of you. But just another plug for our Matrix tool, if you do go to matrix.mctac.org, that's our Matrix website, you'll be able to find all of this information that's right here on the slide on our Matrix tool as well. So for this presentation, we just pulled it all together into one slide, but just want to make sure that you know this is also available on the Matrix tool on MCTAC's website. So again, this is important contact information that we wanted to make sure everyone had access to. And with that, I'm actually going to start wrapping up. We don't have questions today because today is a pre-recorded webinar. But if you do have any questions in the future, please feel free to send them to MCTAC. We've listed our email address, mctac.info@nyu.edu. We do quickly read through all the emails that we get and try and respond to them in as timely a fashion as possible. If we aren't able to answer the question, we'll often refer you back to the state or to the resources that might have the information necessary. So with that, I think we're done for this afternoon. We want to thank all of those of you who listen to this in the future, and to Doug and Emily and Andy and our colleague Morgan for helping us to run this webinar today. Doug and Emily, is there anything else you might want to add? Andy, anything else?
No, I think that's it. Thanks for pulling us all together.
Yes, we appreciate it.
All right. Thanks, everyone. Take care.
All right. Take care.